Hello, I am Dr. Pavis and today's topic is nasopharyngeal angiofibroma. Nasopharyngeal angiofibroma, as we enter the nasopharynx, we see there are many benign tumors. Out of all these benign tumors, the most common tumor is nasopharyngeal angiofibroma. But nasopharyngeal angiofibroma is a very rare benign tumor. It is locally invasive. This nasopharyngeal angiofibroma, it occurs in the second decade of life when testosterone becomes active. Usually these patients have a hematomatous nidus in the nasopharynx. When testosterone acts on that hematomatous nidus, that grows into angiofibroma. So this benign tumor is dependent on testosterone. So the second thing is, what is the most common site of origin of this angiofibroma? Most common site of origin recently believed after latest investigations is the posterior part of nasal cavity. Where in the posterior part of nasal cavity does this tumor arise? It arises from the superior margin of sphenopalatine foramen. Then we have what is the pathology of this tumor. As we know, angio means a vessel and fibroma means fibrous tissue. We have this angiofibroma. It comprises of fibrous tissue and vessels. As vessels love to contract, this tumor may bleed profusely. After this, we come to what are the extensions of this tumor. As this tumor grows in the posterior part of nasal cavity, it extends into the nasal cavity. Number one, from nasal cavity it may enter into the paranasal sinuses. Number two, it may go intracranially through the cribriform palate or ethmoid sinus. From anterior temporal fossa, it may go into the middle cranial fossa, anterior cranial fossa, then it may enter the middle cranial fossa, and after that it may go, while it is still in the nasal cavity, it may go to infratemporal fossa, it may go to maxillary fossa, and it may go into the posterior wall of maxilla. It may even block eustachian tube, and it may reach the cheek and cause the swelling in the cheek and may present as a swelling in the cheek. After this, we know that this tumor, what is the blood supply of this tumor, then we go to what are the clinical features of this tumor. So we discuss what are the clinical features of the tumor. What is the most common age group affected is 1 is 10 to 20 years, and most common group is affected is 10 to 20 years. Males are exclusively affected, and it is rarely occurs in adult male, or rarely occurs in elderly. And what are the clinical features? It is profuse bleeding, spontaneous bleeding, exclusive bleeding. Second is denasal speech or nasal obstruction. Third is a mass in the nasopharynx. And the fourth is we may have a cranial nerve. We may have cranial nerve involvement. We may have swelling in the cheek. We may have proptosis. We may have other symptoms in the eye due to the extension. Or when it goes intracranially, we may have some symptoms due to involvement of the cranial nerves. After that, we have how we diagnose this tumor. The tumor may be diagnosed by clinical picture and biopsy. As this tumor bleeds profusely, we have to remember that the biopsy has to be taken in general anesthesia so that the patient doesn't bleed too much. After that, what are the investigations? We do CT scan of the tumor to know the extent and the extension of the tumor. As CT scan has become very popular and it is the investigation of choice. Now in CT scan we may come across Hallman sign or antral sign. What is this Hallman-Miller sign, or what is this antral sign? It is the anterior bowing of the posterior maxillary sinus wall. It is the anterior bowing, that is, tumor is posterior to it, so the posterior wall is anteriorly bowed, and this is hallmark of angiofibroma. After that, we have MRI. MRI scan can tell us about the origin, about the extension, and about the size of the tumor, and it may give us a clue about the vascularity of the tumor. Then we have angiography. We do angiography as we want to know before surgery what is the vessel which is feeding this tumor. If this vessel is most commonly fed by vessels from the external carotid system. As when we observe that there is a vessel in the external carotid which is coming from the external carotid system, and we want to embolize it so that during operation there is less bleeding. But there are two things which we have to remember. If there is intracranial invasion, that part of the tumor is supplied by the internal carotid artery system, and we never embolize internal carotid system. We don't embolize that, and we only embolize the part if it is not intracranial invasion. If there is no intracranial invasion, and if in extracranial extracarotid artery system is supplying the tumor. When we embolize, we have to remember one more thing. We have to do the surgery within 48 hours, between 24, ideally after 24 hours, and at the most we may delay the surgery up to 48 hours, because after 48 hours the collateral circulation develops. So we go now from there, we take that what is the treatment of this tumor. What is the treatment of this tumor? Surgery is the most common and ideal approach, ideal treatment for this tumor, and there is no watch and wait policy applied to this tumor. As previously done, now we say that we don't need to wait and we don't need to watch. So now there are different approaches. Now there is surgery, then there is chemo plus radio, and then there are hormonal management. But what is the surgery? What are the surgical approaches to this? First of all, we have transpalatine approach. Then we have Sardan's approach, which is a combination of transpalatine and infralabial approach. Then we have another endoscopic approach, endoscopic surgery for this. After that, we have lateral rhinotomy and medial maxillectomy. It has two approaches, two sub approaches. One is the fascial incision, and second is the degluing approach. And after that, we have another, that is sewing approach or V's approach. It is the we do fascial translocation approach. Then we have infratemporal fossa approach, and after that we have intracranial extracranial approaches to this tumor. Then we have, what is the recurrence rate of this tumor? It is 35%. 35% is the recurrence rate of this tumor, but you know that when it recurs, we observe it. After that, we do revision surgery, and sometimes we may go for radiotherapy. What is radiotherapy? What is role of radiotherapy in angiofibroma? Radiotherapy dose is 3000 to 3500 CGY, and the response occurs slowly. It occurs between 1 to 3 years, takes 1 to 3 years to occur. Then we have chemotherapy. In chemotherapy, we use doxorubicin, daunorubicin, and vincristine, and dicarbazine. So now we have, sometimes we use, as we say that this tumor is hormone dependent, it depends on testosterone, we may use which hormone? We may use diethylstilbestrol or flutamide. Then flutamide is androgen blocker, but these drugs have been used previously without any improvement in the tumor. No clinical or no regression of tumor has been noted. And then so let's conclude our talk This is all about infrontum, this nasopharyngeal angiofibroma. Thank you. Please like and subscribe my channel.